Hello, everyone. I'm Dr. Lee Avalali, a neuroradiologist from Phoenix, Arizona, and one of the Radiopedia 2025 co-conveners. Welcome to our final Friday live stream before the big event. Now, Radiopedia runs from July 21st to the 25th, and it is shaping up to be the ultimate online radiology event. Across 5 days, you'll experience expert-led lectures, panel discussions, interactive case workshops, anatomy reviews, and educational posters, all on a custom-built platform designed to keep you engaged. Now, live sessions kick off every 4 hours, so no matter where you are in the world, you will be able to join the conversation in real time. And all attendees will have post-event access. Access 30 days for conference-only tickets and 90 days for all access pass holders. We are going to cover all of your favorite topics, from neuro and head and neck to chest, abdomen, breast, you name it, MSK, even more. Now, registration is still open and it is free for all access pass holders and those in 125 low and middle income countries. Or there is also an affordable tiered pricing for everyone else. Full details are on the website. Okay, now let's close out our live stream series with a brilliant lecture from Dr. Imran Lasker, a UK-based radiologist and educator known for his clear teaching style and great sense of humor. Now, today he's taking us through the imaging of joint prostheses. He's going to share insights and cases in a way that only Imran can. Okay, let's get into it. Thank you. Imran, take it away.
Hello and welcome to this video. My name is Dr. Lasker. I'm a consultant radiologist and thank you for having me back, Radiopedia. I'm very excited to be back and we're going to be talking about something a little bit less heavy this year. We're going to be talking about imaging of prostheses. We're going to be talking about prosthetics and imaging of those kind of things. But to be more specific, we're going to be talking about hip replacements. Now, we may need to go back, like really far back, to be able to really think about the complications that used to occur with hip replacements right at the beginning. And some of the complications continue to happen to this day with even the newer versions of hip replacements that we have. Now, if we go all the way back to 1830, okay, no, this is my turn to do this part of the video. You need to be quiet and listen to an old timer like me. Yeah, sure. Yeah, you go for it. You go for it. Now, back in 1830, a German surgeon known as Professor Gluck took on the mammoth task of introducing ivory hip replacements. Now, ivory is a wonderful material. It is strong, it is durable, and can be handcrafted. And as you can see from the handcraftings that they made, these were good enough to be an orthopod's doorstop. Now, before you could get your teeth into this, there was an elephant in the room. Exactly. There were not enough elephants in the room because they're endangered. So then in 1920, we moved on to using glass hip replacements, which was introduced by a surgeon from the USR known as Smith Peterson. These were molded glass implants that were height of fashion, very durable and taken well by the body. But I think you can see through this particular conundrum. Like Mr. Glass versus a flight of stairs, these could result in shattering. Between the 1950s and the 1960s, in the UK, Sir John Charnley revolutionized hip replacements by introducing the chart-topping LFA, which essentially stands for low frictional torque arthroplasty. This design was a huge success. It was made up of 3 main components: stainless steel femoral stem and head, polyethylene Teflon socket component, and PMMA, which is an acrylic bone cement. And so over time, these hip replacements have pretty much been variations of this kind of thing. Is he gone? Honestly, he'd do anything to keep your attention. Anyway, so there's a few different kinds of hip replacements that exist. So you've got your total hip replacement, you've got your short stem hip arthroplasty, you've got your hip hemiarthroplasty, and you've also got something called a hip resurfacing arthroplasty. Now, each one has slightly differing imaging appearances. Now, when you're looking at a total hip arthroplasty, that's where the surgeon's gone in, taken away the femoral head, and taken away the acetabular cartilage as well. So you've got the femoral head and you've got the acetabular cup, which you can see on the X-ray. Now, when you have a short stem hip arthroplasty, that's where you kind of got a shorter femoral component to the replacement itself. And as you can see, there's a definite difference between the two here. Now, when you move on to a hemi-arthroplasty, that's when you get half of the hip that's been replaced. Now, when you get half of the hip that's been replaced, you're actually only replacing the femoral head. And there can be circumstances where that may be more useful for a patient. And so you've got your native acetabulum and you've got a non-native femoral head. And in that situation, you won't see an acetabular cup at all. In fact, you just see the femoral head articulating within the normal anatomical acetabulum that exists. And then you move on to something called hip resurfacing arthroplasty. And these ones kind of look a bit shorter, a little more stubbier, and a bit more fatter. And that's exactly what they are. And that enables the person to have a little bit more flexibility and is really useful for slightly more active patients. As a result of all this metalwork, as you can imagine, imaging can be a little bit of a challenge. And so, yes, you can use ultrasound in the first instance, and that can be a really good way to look at some of the soft tissue structures where there's like an inflamed bursa, a collection, some fluid where it shouldn't be, or maybe even some sort of big mass that shouldn't be there either. But then when you want to move on from that, you do want to end up going to CT. But as you can imagine, straight away, you're starting to have issues with some of the metalwork causing some artifact. And that's when you can use something known as metallic artifact reduction, otherwise known as MARS. Now, this is particularly useful. It kind of reduces the artifact from the metalwork. But again, sometimes the images can still be quite limited. Same for MRI, you can try and use metal artifact reduction. But again, imaging can be a little bit limited because of the amount of artifact that exists. So there are a multitude of complications that can occur from any kind of hip replacement. But in general, they can be put down into two main categories. One is going to be migrational, and the other is going to be a more reactionary complication that can occur. Now, you can imagine the situation, right? You've gone and got a foreign body in situ, and your body may not want it there, and may want to build a wall or maybe just expel that piece of foreign material out. Now, the fast and quick way to do it is just to fracture. And what can happen is you can get something called a periprosthetic fracture. Now, periprosthetic fractures can happen during the procedure itself, because as you can imagine, orthopods are sort of hammering away and all that kind of stuff to put these things in. But they can actually happen over time, and that can be as a result of the altered biomechanics of the hip replacement itself. Now, because of the fracture, you may have areas of bone that are not as strong as they used to be, or you may have, as a result of the prosthesis itself, have weight being pushed into different areas of the femur that otherwise shouldn't, and therefore results in weakening and therefore result in periprosthetic fractures. Now, the other kind of migrationary issues that you can have, which is a little bit more common, is loosening. I mean, you can imagine it from the hip replacement's point of view, right? You've been working hard, you've been punching in your card. 8 hours for what? Oh, tell me what I've got. I've got this feeling that at times it's holding me down. I'll hit the ceiling or tear up this town, so I've got to cut loose, hip loose. Now, the whole way that this loosening is mediated, and actually is the common factor amongst a lot of the problems beyond the fracture, is an inflammatory mediated response. And this can happen as a result of particle accumulation from the actual replacement itself. It can happen from micromotion of the hip replacement itself within the bones. That can result in corrosion, oxidative reactions, and even minor pathogen contamination can result in an overall osteolysis. Now, when you're looking at the prosthesis, generally speaking, we'd say that a 1 millimeter radiolucency around the prosthesis is actually okay. We can get away with that. Between 1 and 2, we're starting to get a little bit worried. But beyond 2 millimeters, we are going to start worrying that there's a significant loosening, especially if this has happened over a sequential amount of time. Now, there are more subtle migrations that can happen over time as well. One of these subtle migrations is known as protrusio acetabular, which is essentially migration of the femoral head towards the pelvic inlet where there's loss of bone stock of the acetabulum. And you can literally see that there is a fair bit of thinning along the inner aspect of the pelvic brim. Something that's slightly related to that is where you've got total hip replacements and you've got the intrapelvic cup migration. So you've got the acetabular cup, and over time that also starts to migrate, but this time the whole thing starts to go inwards towards the pelvic brim. Going along the lines of migration, sometimes you have intraprosthetic migrations, as it were, and that's where you get the acetabular component, and you've got your femoral head component, and the actual material inside the acetabular component starts to wear away, and you get something called polyethylene wear. And in these particular kinds of scans, you can actually see that there is a slightly eccentric position of the femoral head located within the acetabular component of the prosthesis. Okay, so with that, why don't we just go through a few examples of migrationary complications of hip replacements? Thank you for having me back, and we are now going to go through a few cases. So when we go through to case number 1, we have an obese lady who was admitted to the ER, which is American for A&E, with pain in the right hip after falling at home. So when we look at this particular x-ray, we can see that there is the total hip replacement that's sitting there. We've got the acetabular cup, which looks like something from Mad Max, and you've got the actual hip femoral prosthesis that is located over here. Now, as you kind of draw around the femur, you can see that there is what looks like lack of femur. That's right. This femoral component just wants to run away. It's gone. It has decided to leave the building. You can see that there's a significant fracture that is going through here. And this prosthesis is essentially just staying there, lying in the wind. Now, the next case was a case of hip pain in prosthesis, which was implanted almost 14 years ago. Now, if we have a look at this particular image, we have some wire fixation located in this region. Now, when you zoom into this area here, you can start to notice that there is a bit of radiolucency lying on the inner aspect of this hip replacement. But this one smoothly goes along the interior aspect over here, and there's some more smooth radiolucency located on the outer aspect of the replacement there as well. So therefore, this would be in keeping with loosening of the hip replacement rather than a periprosthetic fracture. Now, interestingly, with this particular view, you can see there is some herniation of some of the cement into the pelvic brim area as well. Now, the next patient is a hip prosthesis from a few years ago, where the patient is complaining of pain, but no trauma on this patient whatsoever. Having a look at this one, you can see that they've got a total hip replacement, and here you can see that they've got a femoral stem and the femoral head that is located here. No acetabular component this time, but this time you can see that there is significant loss of acetabular bone over here, therefore suggesting that this entire thing has migrated inwards towards the pelvic brim, causing some inward indentation of the pelvic brim as well. This would be in keeping with protrusio acetabuli. Now, interestingly, with this particular case, if we zoom in, we can see some abnormal calcifications located within the superlateral aspect of the hip. This is heterotopic calcification that can also occur post-hip replacement surgery. Now, if this gets particularly thick, you can have significant impingement all the way through to ankylosis of the joint itself. Now, this next patient is someone who's got bilateral hip arthroplasty 10 years earlier with worsening right-sided hip pain. And when we look at the scanogram even, you can see that the femoral head is located quite nicely here. But when you come across to this side, there's a distinct lack of joint space involving the superior aspect of the acetabulum. Therefore, this would be consistent with an eccentric position of the hip located within the hip replacement, and therefore consistent with polyethylene wear. Coming across to the CT scan, this is again nicely demonstrated by the complete lack of joint space located when compared to the other side. Here there's lack of joint space, and here this is the normal amount of joint space. Interestingly, when you do zoom into the more superlateral aspect of both of these hips, there is a distinct loss of bone stock, which therefore may be consistent with some focal osteolysis rather than a full-on loosening that is happening as well. So this is a 70-year-old person complaining of hip pain, and this time you can see that the hip does not look right from the outset. So this is going to be the interior brim, and this entire hip prosthesis has moved inwards. A bit like the protrusor acetabular, but in this case we do have a acetabular component, therefore meaning that this would be more in keeping with intrapelvic cup migration. This next case is of a 65-year-old lady, 5 weeks post-hip replacement. After a fall, she presented with a painful left hip and shortened and internally rotated left leg. Now, hopefully you can see that the hip is not going inwards. It is not going to be protrusor acetabular. It's not intrapelvic migration of the acetabular component. The acetabulum does not have an acetabular component. In this particular situation, you can actually see that there is a significant dislocation of the hip joint itself. This has completely come out of place, so therefore this would be consistent with a dislocated total hip replacement. Now, moving on to the reactionary side of things, again, very much related to the inflammatory process that we were talking about earlier. Now, the inflammatory process can happen very locally within the bone or the hip joint itself, or can happen around the joint fluid and the synovial lining as well. One of the more reactionary reactions to a hip replacement is known as metal-on-metal pseudotumor. Now, interestingly, the pathophysiology behind this is really poorly understood, but you end up getting a sort of inflammatory mass which is essentially sterile and can be seen on the MRI scan as this abnormal lesion-looking material located within the region of the prosthesis. You can actually find this on ultrasound as well. Now, the big key differentiator between something like a pseudotumor and infection is that with a pseudotumor, they are much more well-defined, and you also get a very low signal rim around it. Moving on to another kind of reactionary reaction to a hip replacement is something called ALVAL, not to be confused with Alvin and the Chipmunks. This is known as aseptic lymphocyte dominant vasculitis associated lesion. And again, this is going to be a chronic inflammatory response to metal particles from the hip replacement as well. And moving along the spectrum of metal on metal reactions, there's something else called metallosis. This is where you actually get metal particles located within macrophages, which is different from the lymphocytes from alveoli. So you essentially get bits of metal that are located within the hip joint. It can give you a cloudy looking appearance on X-ray and can give you a cloudy appearance on a CT scan as well. The next reactionary style of reaction that you can get to hip replacements is something called bursitis. As you can imagine, the trochanteric bursa is very nearby. So as a result of the mechanics of the movement of the hip, you can actually end up getting significant inflammation of the bursa itself. You can even get some tendon abnormalities, i.e. tendon tears or tendinopathies as a result of the altered biomechanics of a hip replacement. And occasionally you'll also get something known as pseudobursa, which are essentially large pockets of fluid that communicate with the hip joint but can extend very, very far away from the joint itself. Now, the final kind of reactionary sort of process that you can have is something called stress shielding. Now, as you can imagine, when you do have a hip replacement or any sort of prosthesis, you can have, again, altered biomechanics in terms of where the weight is distributed amongst the bone that is left behind. So generally speaking, the way that your bone keeps its density is by reacting to the amount of weight around. So that's why when you get astronauts going up into space, they actually end up having a loss of bone density because they have no real weight on their bones to push their bones to continue to be forming. Now, similar to that, if you do have a hip replacement, the weight is going to a different area of bone. The areas of bones that don't have as much weight as they used to will start to essentially become less dense, and that is known as stress shielding. Cool. And now what we're going to do is go through a few reactionary complications of replacement. So this next person, 65 years old, and they've got a post-bilateral total hip replacement. Currently, the right hip is restricted range of movement. Now, when we go across to the X-ray, we can see that this hip replacement looks okay. It doesn't look like there's any way of loosening. There's no migration of the femoral or acetabular component into the pelvic brim. There's good bone stock located within this region over here. But when we come across to this side, there's not much in the way of loosening, but there is what looks like this radiolucency located within the region of the greater trochanter. Now, this is a very uniform density and almost looks like there's some scalloping rather than absolute resorption or absorption. Interestingly, they also have a few foci of heterotropic calcifications located within the region of the greater trochanter. Given the linear appearance, this may actually represent calcifications located within the trochanteric bursa, or even calcifications located within the abductor tendons. So here on the ultrasound, you can see a very large, predominantly hypoechoic lesion located within the region of interest. This is a very lobulated appearance, predominantly of hypoechogenicity, and there was no internal Doppler flow demonstrated within it. Moving on to the MRI scan, these are the axial T2 weighted images, and we can see that there is significant synovial thickening located within this area over here. This corresponds to the previously identified area of abnormality located on the X-ray and the ultrasound study. Now, when we look at this particular MRI scan in the coronal views, this is the T1 weighted images. And again, we can see this particular area located over here, which corresponds to the previous radiograph. Overall, this combination of findings would suggest that this would be in keeping with a metal on metal pseudo tumor. So we're going to move on to this next case. I know you're going to say that, hang on, this is not a hip replacement. Relax. I'm going to just do a quick comparison between pseudotumor and infection. Now, with the pseudotumor, there wasn't much in the way of edema involving the actual bones or the surrounding soft tissues. In this situation, we can see there's an extensive amount of fluid within the hip joint. There's an extensive amount of edema involving the femoral head and the acetabular roof. And when you come across to the T1 weighted images, there's a significant loss of the normal bone marrow signal as well. So therefore, this would be more in keeping with underlying infection, and this may happen with a hip replacement in situ. So the difference between the pseudotumor and infection is that the infection will have a lot of edema, you'll have lack of T1 signal, lots of bone marrow edema as well, and you will have less of a capsule, whereas with a pseudotumor, you have a thick, low signal capsule. So this next gentleman here had a routine follow-up of their hip replacement surgery. And you can see here that these are total hip replacements. You do have the acetabular components and the femoral components as well. You do have a few foci of heterotopic calcifications located within the greater trochanter over here and over here. But this arrow nicely points out there's another area of radiolucency. Now, this radiolucency is beneath the hip replacement. It is actually closely associated with hip replacement. It doesn't go along the hip replacement as you'd expect with loosening. Now, it doesn't show much in the way of any mass effect. You can actually see the normal bone that is located over here. Now, this would be in keeping with stress shielding. Essentially, what's happened is that most of the weight now is going through this area of the bone rather than through this area of the bone, resulting in a lack of mineral density located over this region because of the dynamic process in which the bone is made. Now, this is a slightly more reactionary appearance, coronal stir sequence through the hip replacement. There is a bit of artifact from the hip replacement. As you scroll through, you can actually see that there is some fluid located within the region of the greater trochanter. Now, interestingly, this is where you should have the gluteal tendons located, but here there's no gluteal tendons whatsoever. Therefore, this would be more in keeping with a trochanteric bursitis and concurrent tears of the gluteal tendons. When we come across to the axial views, we can see that there is a distinct lack of tendon that's going into the greater trochanter, and on top of that, there's a significant amount of muscular atrophy involving the gluteus muscles in general. Back to you. What does the future hold for replacement and all that kind of thing? Well, obviously, the methods are getting better, materials are getting better. We'll even start to consider using robotics as part of the hip replacements that we have, not just in terms of the prosthesis itself, but also putting the prosthetics in the first place, which is really, really interesting. Also getting 3D printed hip replacements. I mean, we may find ourselves in a situation where your grandparents are calling you up, asking you to print off a new hip for them. And then obviously, I think we all know where this is all headed, right? We're headed towards a future of adamantium. Yeah. Anyway, I hope that was useful. Thank you so much for having me back, and I'll see you next time. Bye. Before you go, there's one big thank you that should be given, and I will just have a look for it now. Imran said that we definitely need to mention these guys. He said, thank you to Radiopedia. What is that? Like a encyclopedia of radios? A radioactive encyclopedia? What is that exactly? Anyway, strange name, but he says thank you. So thank you. Bye.
Absolutely brilliant. Thank you so much, Imran. Now, it's no small feat to make prosthesis imaging both practical and fun. But Imran nailed it. Thank you, Imran. Now, if you want more from Imran, don't miss his case-based contribution to the MSK workshop. It's just one of many hands-on sessions packed into this year's conference. So that's a wrap on our live stream series. And the next time you hear from me, it'll be from Radiopedia 2025, and we will be live. We've got an incredible lineup waiting for you. We have immersive workshops, interactive case scrolls, our posters from contributors around the world. We even have panel discussions and quizzes and just really a vibrant global community ready to learn together. And remember, depending on your pass, you'll get 30 to 90 days of post-event access, so you can learn at your own pace. So now is the moment. Register, spread the word, and, of course, get ready. We can't wait to welcome you to Radiopedia 2025, and I can't wait to see you there. Bye for now.